think we are live. Yes, we are live. And I need to have my YouTube channel open here to see what people are seeing on YouTube. Sorry, just give me a second. We actually already live. There are people joining. Actually, I can see it from here. Yeah. Okay. I'll start the introduction in English, and then I will give a couple of words in French. Oh, sorry. I need to get my microphone here. Okay. We have 4 people live already that have joined us. Okay, we'll not wait more as people will be joining the platform. We will just make sure we start. So, hi everybody, and welcome to this first webinar series of Global Physio Training in partnership with Labou Education and Neuro Rehabilitation Society of Cameroon. As we've been trying to do for the past couple of weeks, we've been working hard. The Global Physio Training has been working hard to set up this series of webinars, and we are kicking off today with this first webinar. That is, it's a webinar. It's a 3-series webinar on neuromusculoskeletal manual therapy that would end up in March with a 3-day practical course. So as you may see on the screen, the first webinar is the one of today that will be focused on introduction to mechanotherapy, actually. And it will be presented by one of our main team members. Before we get into that in more details, I would like to start by introducing the trainers that would be involved in the 3 webinar series and in the practical course that will be upcoming. So I would start with myself. A lot of you already know me. I'm Valery Labou. I'm a physical therapist from Cameroon. I've been working extensively in neurorehabilitation and in sport physiotherapy. I hold a master's degree in neuroscience, and then I've been practicing for years now, mainly in neurorehabilitation. As a matter of fact, I created the Cameroon Society of Neurorehabilitation, and I'm one of the those involved in the. If you go on the website of the World Federation for Neurorehabilitation, you will see myself as representing Cameroon. And my experience in sport have been for almost the past 15 years. Have been involved in sport to the highest level, notably with a lot of national team. But the main team that I've been working with would be the national team of volleyball that I've accompanied in a lot of world championships and at a local level. In my quest of knowledge, I also spent some time working in Europe in robotics and neurorehabilitation. I actually did a lot of work for a company called Exotech, which works with a robot that's called Luna EMG, which is a EMG-driven robot that I participated in the building. So, and for the past few years, I would say for almost a year now, the 2 gentlemen that you are seeing on the screen, we've met and we noticed our common interest to share knowledge, and it's how this project was built. So I will introduce the next trainer. He would have the opportunity to present himself. This would be Nate. Dr. Nate, you have the floor.
Thank you, Val. Hey, Dr. Nate Henry, state of Colorado in the United States. I've been a physical therapist for going on 16, 17 years now. I spent 22 years in the U.S. Army, and 15 of those years was as a physical therapist. So I have a lot of experience treating soldiers as well as their family members and retirees. also spent extensive time at the collegiate level treating athletes, and I've covered things such as rugby and lacrosse and wrestling and basketball and American football. I have done a number of taking advantage of some education opportunities. So I have 2 doctorate degrees. I've done 2 fellowships, one in sports and one in manual therapy. And I've done 2 board certifications, again, one in sports and one in manual therapy. I definitely enjoy outdoor activities and try to help my patients do the same. We have a clinic here in Colorado Springs that treats the outdoor athletes. So mountain bikers, runners, hikers, campers, skiers and snowboarders, as well as those that just like to stay generally active. And I'm excited for what Global Physio Training can bring to Cameroon.
I'll be introducing now Dr. Clint Serafino, who is the one that is going to be presenting the webinar of today. So, yeah. So, Clint, you have the floor.
Awesome. Hey, great to meet all of you. My name is Clint Serafino. I'm a physical therapist. I've been in physical therapy for 13 years. I met Nate on one of the education endeavors that he went on. We met in fellowship. I have a fellowship in orthopedic manual physical therapy. During that time, I decided I really wanted to understand what was happening when we put our hands on patients. Right now I have a clinic in South Carolina in the United States. Similar to Nate, we work with active adults, people who may have some nagging injuries, but want to stay active, wants to stay involved in their kids' lives. Similar to Nate, be outdoors and move around. I've treated at all sorts of levels. I've treated in hospital systems. For a 2-year period of time, I worked with special operations in the U.S. military. And what was cool about that experience is a physical therapist in the military gets to function as a primary care provider. It was at that point in time that I really developed the skills to screen patients, evaluate them, decide how to best serve them, whether they needed physical therapy, whether they needed a referral to orthopedic surgery or physiatry or general med. So it was a really cool experience then to come back into the civilian sector in the United States and offer the same kind of structure to the community in which that I work. I'm excited to talk to you today about this class that we've built for Cameroon. We'll deliver this class in March of the upcoming year in 2025. These 3 webinars are really critical to help us all understand a bit of a foundation where we're going to start to influence our patients and what's actually happening, not only for our patients' experience, but also from a tissue and a cellular level. What is it about us putting our hands on people that seems to be effective in helping them get over some pain, get over some dysfunction, and get back to the things that are most important to them. So the presentation I've built for us today is a kind of a foundational lecture on neuromusculoskeletal manual therapy, and in particular, mechanotherapy and mechanotransduction. In the future webinars, we'll chat more about neuromusculoskeletal manual therapy and really establish a framework to understand what happens at the nervous system level, the muscles and bones level, so that we can understand exactly the best ways to help our patients. Today, I want to chat more about the actual physiology of what's going to happen when we touch patients, how their tissues respond, what's happening at a cellular level, and even down to the DNA and the decisions that the DNA get to make to figure out how do we repair, how do we fix what's going on. Foundationally here, manual therapy, being competent in manual therapy really is a good framework and a cost-effective framework to help our patients get better in the absence of resources. Both in the United States and internationally, there are many populations that don't have the financial resources or simply local access to good healthcare and good medical providers. Being a strong manual therapist is an opportunity to provide some intervention where in the absence of quality healthcare, quality treatment, these patients may otherwise not be able to have care they need and live with dysfunction. One thing that's interesting, just as far as internationally, whether it's Europe, Italy, and the UK, whether it's South America, the international stance on manual therapy, there are actually guidelines that would suggest, hey, the first kind of levels for treating some patients doesn't need to be pharmaceuticals, doesn't need to be surgery. Those things are rather costly sometimes, most times, but also they're rather invasive. And so the international guidelines really are, how do we make a meaningful change for patients being competent in manual therapy? There are a lot of mechanisms at play here. You can review this slide, but essentially all of our body tissues, the nervous system, muscles and joints and bones and cartilage, all of these tissues respond in part to manual therapy. And we'll chat more about that in a few minutes. But essentially, the deeper dive on the course that we're gonna host in Cameroon, we'll look at more of these mechanisms to understand what happens at the nervous system level, at the muscle level. How do we change tone? How do we make the joints move better and not be so stiff? Really, a hands-on approach, a competent manual therapist can offer quite a bit of utility in the absence of more expensive and more costly resources. So this term that I use is mechanotherapy. And you can see here on the slide, mechanotherapy is a term that dates back all the way to 1890. There's a definition from the old Oxford English Dictionary, the employment of mechanical means for the cure of disease. But it wasn't until 2009 and 2016 that a couple of researchers in Canada and in the United States redefined what mechanotherapy really is. And so Thompson, we're going to walk through both Thompson and Kahn's article in this webinar. Thompson describes mechanical therapy or mechanotherapy as any intervention that introduces mechanical forces with the goal of altering molecular pathways and inducing a cellular response that enhances tissue growth, modeling, remodeling, and repair. And the question I'll pose to you all as physical therapists or other healthcare providers is, isn't that what we're trying to do for our patients? Aren't we trying to create interventions and use skills to help these patients' tissues grow and remodel and repair? I believe it is. And I believe it takes a competent manual therapist and a variety of manual techniques to really be proficient in helping our patients make those changes. Thompson walks through a series of reactions, and this slide really describes that. On the left-hand side here, that blue box, that describes like the start of a manual impulse or a manual stimulus into the patient's body. So maybe this is like a mobilization for the spine, or maybe it's a massage technique. But the mechanical stimulus actually influences the tissues. The tissues then signal the cells that make up those tissues, and it's the cell response then that gets to communicate directly to the nucleus of each cell to create a cascade of change. And then what's really cool about this slide is Thompson describes not one, but two kind of feedback loops. The first is that kind of right-hand red slide or red box. The cells begin to signal to each other the need for some sort of change. And then the molecules and the actual cellular response, these kind of chemicals that are created, spread across the cellular matrix to then make a tissue change. And it's pretty cool that we have not one, but two kind of systems here, two kind of feedback loops, in order to make sure we get information from the outside world to the tissues, to the cells that need to grow and model and remodel and repair. These forces can be extrinsic or intrinsic. And what I mean by that is extrinsic forces is kind of what we're talking about today. hands-on patients, whether we're using a certain intervention like electrical stim, maybe we're using an intervention like acupuncture or dry needling, or maybe it's just a massage technique or a mobilization with our hands. That technique is extrinsic. Someone is providing that intervention to a patient. An intrinsic force is, for example, diaphragmatic breathing or exercise, where the patient is in control of that movement and that motion. And those forces that are created, they follow the same cascade, but they're managed intrinsically by the patient. In 2009, Kahn wrote this article about mechanotransduction and mechanotherapy, and he outlines really 4 major topics, and we're going to deep dive into each of these topics. The first is pretty interesting. At a cellular level, our cells are uniquely designed to respond to a variety of signals, but one of those is a mechanical stimulus. We have a cell membrane, it's called a phospholipid bilayer, that goes around the cells, and it's semi-permeable, meaning you don't just get information freely traveling in and out of the cells. You have gatekeepers along that membrane that help to regulate the cell activity. The cytoskeleton is actually the internal scaffolding for each of these cells. And when you look at a cell on under a microscope, it's hard to appreciate the 3-dimensional nature of what these cells actually look like. But these cells are 3-dimensional, and it's the cytoskeleton that creates that kind of scaffolding, or it's made up of that scaffolding to create the structure of the cell. And then the integrins are a certain type of receptor that respond only to a mechanical change in position. And uniquely here, the integrin switches are kind of the gate and the connection between intracellular cytoplasm and the intracellular cytoskeleton and the extracellular cytoskeleton. Uniquely here, as I mentioned previously, these are some of the same structures that the pharmaceutical companies, they modify the way cells behave by addressing these and other receptor sites on the cell membrane. So we can modulate these cells, we can address these cells with our hands and with other interventions, just like or similar to the mechanisms that a pharmaceutical, a drug, or a medicine is able to influence cellular activity. This slide is really busy, so focus now on just the box at the top. The box at the top is signaling or it's pointing out that phospholipid bilayer, that's the membrane there. And then there are several examples here of certain kinds of gatekeepers, and these gatekeepers respond to unique stimuli. So we have a stretch activated ion channel, that's a different charge there that's going to bind to that receptor and then kick off a response. We have a growth hormone or certain things, but essentially here, the one on the top right is an example of that integrin switch. And you can see it's kind of shaded in the down position, and then it's bold in the top position with that arrow. Essentially here, that integrin switch has been moved. And then that integrin switch then gets to communicate from the outside of the cell. Now information is communicated into the cell. The next layer here is this mechanical coupling response. And this word is mechanotransduction. Essentially, this is the way, kind of like the Thompson article, that information travels from the outside world to the tissues, to the cells, and eventually to the nucleus of each cell. What you see here is the bottom left, yellow wavy collagen fibers. The bottom left shows a green cell body, and then inside that cell is the nucleus. The middle pane of this illustration shows that those black lines have shifted, and that's a stretching kind of illustration. And then the bottom right side shows with that stretch, there's a coupled response now of shearing and compression forces that are exerted on the cell itself and therefore on the cell nucleus. These kinds of mechanical forces are the catalyst for that the biochemical signaling that are the catalyst for the nucleus response. So here's the example again, but now we're going to look at the nucleus at the bottom. Once that integrin switch is turned on, the biochemical signals move into the cell and they talk directly to the nucleus. We all know the nucleus is what houses our DNA. Every cell in our body has our DNA, every piece of the code. And so from that DNA, we get a decision on what needs to happen with this cell. That decision is called gene upregulation or even downregulation it could be. But essentially here, there are two pathways for a mechanical force to signal the integrin switch to then directly or indirectly influence the nucleus. And the nucleus then changes and modifies gene expression. Remember, the whole goal by the definition is to help our tissues grow, model, remodel, and repair. The fact that there are two systems here, a direct pathway and an indirect pathway, suggests that, hey, this process is pretty important. Redundancy in the systems suggests importance. So here's another illustration. This comes from the Khan article again. You can see on the right-hand side, if we zoom way in, here's an example of those integrin switches. And one of them is attached directly to the cytoplasm. That's that green cytoskeleton. That's that scaffolding that makes up the inside of the cell. And the other one is also connected to, we have a direct pathway on the top. And then if I change this slide, you can see this is the example of an indirect pathway on the bottom, where once those switches are toggled on, then we get that cascade of information kicking off another signal to then talk to the nucleus. The main point with this slide is that there are two pathways, a direct pathway and an indirect pathway, to get information from the outside of the cell into speaking to the cell nucleus itself. That gene upregulation is then called the effector response. Whether we turn genes on or we modify gene expression, these are the instructions that the nucleus gets to decide and send out of the cell. This is our cellular response. This is the biochemical response to that is a change in gene expression to change the way our cells are functioning. That information, the effector response in particular, is spread not just inside the cell, but it's spread to adjacent cells via extracellular matrix. And this is the intercellular communication. We're talking cells communicating with other cells. And it's pretty interesting here. It wouldn't do us really any good to signal only one cell at a time. We have millions and billions and trillions of cells in our body. It would be a very inefficient system if we didn't have some sort of communication matrix extracellularly. That means outside of the cells. This is an example of a complementary system so that multiple cells are receiving the information and getting the signaling out of the cells at the same time. The effector response here in this illustration shows the green cell bodies, the nucleus inside each of these cells, and then you can tell there's like a network that connects other cells. So the green is pretty continuous outside of the cells. And then there are small horizontal arrows here. Those are considered gap junctions, or the illustration is demonstrating gap junctions. Gap junctions are unique in that they're kind of like a gate or a trap door. So once that DNA expression, that change is decided, the instructions are sent out of the cell to adjacent cells, out of those cells to other neighboring cells. And it becomes kind of like this, a spreading of information across the extracellular matrix. This again is that intercellular signaling. This is the cell-cell communication. What's unique here about the cell-cell communication is the features that I've just described are really generally applied to all cell types and all tissue types in our bodies. It's not just the collagen fibers and the connective tissues. Instead, bones respond this way, muscles respond this way, cartilage responds this way. We have the ability to signal not just along connective tissues, but across all tissue types. What's unique about this is these are the physical forces that some of you may be familiar with when it comes to physical therapy. Now, the left-hand side describes or lists many of these kind of cool or novel manual therapy techniques. We have manipulation. That's kind of like the chiropractor adjustment, crack of the spine. Mobilization, maybe we're going to mobilize joints in the shoulder or the hip. We have dry needling, which is similar to acupuncture. We have soft tissue mobilization. These are things on the left-hand side that many therapists are competent in or aware of that they would describe as physical forces. But the right-hand side is the stuff that we don't really think of when it comes to physical forces. Electric stim, the use of laser or ultrasound, these kinds of modalities are still a physical force exerted on these cells. That means when you're using STEM, you're communicating from the outside world to the tissues, to the cells themselves. But we don't think about these kind of modalities also being physical forces. I usually say, check the physics textbook again. These are all measurable waves, measurable forces. Each of our patients may have conditions that would either positively or negatively describe, or let me rephrase. Our patients may respond in ways to manual and physical forces. And we can use a couple of these examples as a framework to build on. Wolff's Law, if you're not familiar, Wolff's Law states that bone grows according to the forces applied to it. So maybe after a surgery or after a fracture of your arm or your leg, you want to start to expose those areas to weight bearing, to loading, so that we get the bones to reform and heal around that fracture site or around the surgery site. Davis's law is the exact same thing, except for it applies to non-bony structures. We're talking tendons and ligaments primarily. The tendons need to be loaded in order to then adapt to that load and begin to heal. Many of us are familiar from a sport and an exercise perspective. We're familiar with the SAID principle and progressive overload. The SAID principle is specific adaptations to imposed demands. And what that means is when we start to load our muscles, those muscles adapt and they get bigger and or stronger and or more efficient and better endurance. Progressive overload is the same kind of thing. We need to gradually scale that load in order to seek that and develop that adaptation. So those are kind of positive responses to physical forces and manual forces, but there are also some negative responses. Too much sustained posture in the same positions, particularly on our computers, maybe on our phones or devices. Maybe it's a job activity that someone's doing where they're always sitting or they're always bending over and picking up heavy things. Sustained postures really have the same kind of mechanical response. It just becomes negative in nature, and that's where injuries can develop and come from. Particularly here when it comes to repeated traumas, there's a story from Dr. Kahn about a fellow physician. His name is Håkan Alfredson. And what Håkan Alfredson had was a case of bilateral Achilles tendinopathy. That means just pretty significant pain and dysfunction in the Achilles on both sides. And what Dr. Alfredson wanted was to have his colleagues cut his Achilles tendons surgically and then reattach them in order to then help those tissues heal. And of course, that sounds pretty crazy. So no one would do this for him. So what Dr. Alfredson did was try to rupture his Achilles tendons on his own. He was trying to drop his heels off of a step or a stair, and in order to try to rupture the tendons, figuring once they rupture, then someone has to fix them. And the cool part about that experience for Dr. Alfredson is his case of tendinopathy got better. He went through a certain degree of pain in order to then stimulate and load those tendons adequately, and they began to respond to that load and heal themselves from a cellular level. The tendon cells adapted a response. They sent out this information across that same extracellular matrix, and the whole entirety of the tendon repaired and improved. When it comes to arthritic changes in our patients or even in ourselves, arthritis is simply an adaptation of our joints and our bones due to the excessive forces we're putting onto them. There's a study here by Brindjikji in 2015, and what Brindjikji shows is there seems to be an increasing frequency of abnormal arthritis findings, and it seems to increase with age. But the caveat or the interesting part about that article is none of the patients in the study had any pain or any symptoms or any dysfunction. And we're talking about a study that was 3,200 MRIs. That's a lot of pictures to look at. And none of those patients had any symptoms, yet their pictures would show disc degeneration, disc bulges, facet degeneration of the joints, and so on and so on. My point with this slide really is our body is designed to adapt to mechanical and physical forces. It can adapt in a positive way if these forces are used adequately and used correctly. And injury can occur when we demand structures in our body to absorb force that is inappropriate. This slide here is also a little busy. This is a slide we use when we talk about why we would use acupuncture needles and what's actually happening at a cellular response. But I would propose to you in the top left here, instead of just winding up an acupuncture needle, I think we could replace that little graphic with any sort of mechanical input. Maybe it's just a massage technique where we're putting our hands on patients and we're helping, touch those muscles and those tissues. But what happens once we get that physical stimulus into the system, the body begins to respond predictably. So the TRPV1 receptor here is the top left. TRPV1 is a unique receptor. It responds to changes in acidity. It responds to various inflammation processes, but uniquely, it is a certain receptor site that also responds to mechanical load, or just like the integrin switches, some sort of physical load on the cell. When the TRPV1 receptor is activated, it causes a calcium wave to be propagated across the cell. And once the calcium is spreading, ATP, which is our body's energy currency, ATP is expelled from these cells via pannexin channels. ATP in the extracellular matrix outside of these cells is metabolized all the way down to adenosine. The top right-hand receptor there is an A1 receptor. Adenosine can bind to A1 receptors, and then the A1 receptor, when it's active, blocks information along the TTX pathway from being communicated back to the central nervous system. This is a really busy slide. The takeaway is this: mechanical load causes adenosine to block information from being communicated back to the central nervous system, which I think is pretty unique. This is an adenosine-mediated analgesic effect. And maybe some of you have had the experience of maybe having your neck cracked or adjusted by a chiropractor. Maybe you've had the experience of a massage or some other kind of physical technique where you have felt better and you've had less pain after that kind of massage or physical intervention. This is in part one of the explanations for why that actually happens. Uniquely, A1 receptors, when they're activated, that can block pain information from being communicated back to the central nervous system. Really here, this whole mechanotherapy, mechanotransduction introduction is the foundation for, at least for me, what is happening for our patients when we touch them. When we use needles, when we use massage, when we use various techniques, even e-stim or laser or ultrasound, we're able to get a cellular change that helps our patients' tissues begin to remodel in a guided way. That's the summary here. We'll have plenty of time now for a bit of questions, but I'll turn it back over to Val for any further comments and further summary, and we'll rock and roll from there.
Yeah, thank you, Dr. Clint, for the wonderful presentation so far. I think I may just turn on a little quick in French, maybe to just give a very quick summary. I will not dive into what you just mentioned, but I'll just make a quick summary. Donc, je vais prendre la parole en français pour faire un résumé très rapide sans rentrer dans les détails de la présentation qui a été faite. Et un peu comme je vous l'ai toujours dit dans le groupe, l'anglais est la langue scientifique par essence et il faudrait qu'on s'y mette, et c'est un peu dans ce sens-là que nous sommes en train de mobiliser les connaissances venant d'un peu partout. Donc, cette partie de la présentation sur la mécanothérapie, de façon générale, si je veux faire un résumé, dans cette partie, le Dr. Clint parle simplement dans son introduction, il introduisait déjà pourquoi est-ce que la mécanothérapie est importante pour un certain nombre de pathologies et surtout pour un certain type d'environnement, notamment les environnements dans lesquels on est limité en ressources. La mécanothérapie ou la thérapie manuelle de façon générale, les thérapies manuelles sont un outil précieux et efficace dans des zones surtout comme la nôtre, mais également dans des zones aux États-Unis et en Europe où c'est très, très utilisé. Et il serait dommage que dans des espaces comme les nôtres où on est limité en ressources, qu'on ne puisse pas utiliser cette modalité qui est particulièrement efficace et moins chère, puisqu'en réalité, en fin de compte, nous nous servons pratiquement que de nos mains pour produire les résultats escomptés ou pour induire le mécanisme de guérison chez nos patients. Donc, dans cette partie de la présentation, le Dr Clint parle principalement de l'effet mécanique que nous induisons en thérapie manuelle. Donc, c'est pour ça que cette partie a été introduite, l'introduction de la mécanothérapie, les effets de la mécanothérapie dans le cadre de la thérapie manuelle. Puisque dans le cadre de la mécanothérapie, nous induisons des forces extérieures. Et donc, dans cette partie, il explique simplement l'effet que les forces extérieures produisent, par quel mécanisme elles le produisent sur les tissus. Et il rentre simplement dans les détails de la production de forces venant de l'extérieur et l'induction des mécanismes qui sont liés à la guérison jusqu'au niveau cellulaire, simplement. Ok, donc je pense que je vais me limiter à cette partie et lui remettre la parole pour la suite au cas où. Yes, I'm getting back to you in English. I just made a summary of, like a quick summary of what was talked about, mentioning how manual therapy can be a wonderful tool in resource-limited areas, and it would be a pity not to be able to be mainly for those in a resource-limited area, not to be using physical manual therapy as a therapeutic tool. And I was also making sure that everybody understands that at this point, what you mainly talked about, it's how mechanotherapy, that means the force that is induced during manual therapy from the outside inward, induces changes up to the cellular level to produce or to induce tissue healing. So as a summary, that's basically what I mentioned, but he went deeper in his presentation, talking about the different type of mechanical forces that can be induced to tissue to trigger or to enhance the healing process. And as you may see on the summary, some of them could be what we do on an everyday basis: the massage, the acupuncture, exercise, vibration, electrical stimulation, ultrasound. All those are mechanical forces that are induced from the outside inward, and all those forces, notwithstanding their difference, would induce a certain type of load on the tissue and transmit certain type of message to trigger, at the end of the day, the healing process. So I would hand the speech over to Dr. Clint. Maybe unless maybe Dr. Nate wanted to add something onto that before we proceed to the next step.
I think perhaps maybe the most simple takeaway is, just like you said, there's a rationale and there's a reason why being competent in a variety of manual skills is useful for our patients, and it's not until we understand what happens at a tissue and a cellular level that we can kind of understand, hey, there's utility and there's usefulness across all of these physical forces.
Yes, if I could add, guys, the mechanotransduction is the mechanical stimulus causing a chemical response. So medicine worldwide puts a lot of stock in drugs and in other modalities that cause a chemical response. What we need to recognize is that our ability to use our hands and maybe some other tools has a very, a very similar response in inducing a chemical response. So there's a lot of power in that. And that's what this whole thing that Clint has given us is about.
Yeah, great.
So, je pense que nous sommes au terme de la présentation. We just reached the end of our presentation. If some of you may have some questions, I think Dr. Clint, Dr. Nate are all available to answer some of the questions you guys may have. Donc, si vous avez des questions, n'hésitez pas à les poser dans la partie la section des commentaires, et puis je vais les mettre à l'écran. Et puis, le Dr. Clint ou le Dr. Nate et moi-même pourrons répondre à certaines de ces questions. Donc, si vous avez des questions, n'hésitez pas. En attendant que ça se fasse, juste pour revenir un peu sur ce que la précision que le Dr. Nate vient de faire, en fait, l'essence même de cette présentation parle de la mécanotransduction, c'est-à-dire le mécanisme par lequel une force physique appliquée au tissu traverse les tissus et induit une réaction chimique, ou une réaction chimique qui a pour effet donc, de finalement produire un effet thérapeutique. Donc, au quotidien, c'est ce que nous faisons dans la plupart de nos manipulations, parce que quand on parle de thérapie manuelle, on ne parle pas simplement des manipulations vertébrales au sens de faire craquer des articulations. La mobilisation articulaire est une manipulation. Le massage, donc la mobilisation des tissus mous, est une technique de mécanothérapie. L'utilisation d'ultrasons, d'aiguilles d'acupuncture, donc tout ce qui va induire une force venant de l'extérieur sur les tissus va être considéré comme de la mécanotransduction. Donc, ce mécanisme d'induction de force sur les tissus, de quelque nature qu'elle soit vibratoire, qu'elle soit en translation, qu'elle soit en pression, vont se produire, la propagation de cette force-là va être de ce qu'on appelle de la mécanotransduction, et donc induit une réponse chimique au niveau tissulaire ou aussi profond qu'au niveau cellulaire. Et donc induire un mécanisme de réparation tissulaire. So the precision I was just trying to put to bring was just emphasizing that when it comes to manual therapy, everything that we do in physical therapy that is result in inducing a mechanical force. When we talk about manual therapy, it's not just about joint cracking, like joint tissue mobilization, from soft tissue articular mobilization, soft tissue mobilization in massage, be it vibration therapy, dry needling, acupuncture, electrical stimulation, ultrasound, all those through a mechanism that's called mechanotransduction. That is the translation of mechanical force inward into the tissue, would induce a chemical response. And the end goal of that chemical response would be triggering a healing factor. So basically, that is if the takeaway of this course, and that was discussed in detail, where all the different type of mechanical load that could be applied to tissue in terms of mechanical or mechanotherapy, and through the mechanotransduction mechanism, and the targeted tissue and the type of response that is induced through those modalities or those different applications would end up producing, triggering at the end of the healing factor or enhancing the triggering factors. So I think we are 43 minutes right now. Okay, so we have a question. Let me display the question on the screen, and it would be to whoever want to take it. It's a question from Fadima Tunjoya that is asking this question: since any physical stimulation should produce a cellular response, how come you have some patients, for example, after cerebral seizure, stay a long period within the hemiplegic period? So I will leave you gentlemen to any of you that want to take that question. But I think basically she's trying to ask the question on how the chemical response that is being mediated through mechanical response in physical stimulation, how come some patients with a stroke end up still staying that longer in the hemiplegic period?
Yeah. So what I described to you is the body's natural mechanisms. When there is a dysfunction of the other adjacent tissues. If it's a stroke or a seizure or a brain injury, part of those mechanical forces aren't, those mechanisms aren't intact anymore. So maybe this patient has just, very much tone in their arm or their bicep. No matter how much you apply mechanical forces here, if the central nervous system is dysfunctional, then the body is going to respond differently to mechanical forces. We see the same thing in patients with Ehlers-Danlos disease or Ehlers-Danlos syndrome. Ehlers-Danlos is a dysfunction it's a genetic dysfunction of collagen tissues. So they respond very differently to mechanical forces because their system is atypical. If the system is injured or dysfunctional or not typical, then many of these principles may need to be applied differently.
Yeah, if I may add something to that answer, I would just say, notwithstanding that the mechanism might not be intact, but at the end of the day, you have to understand this: the healing process or the therapeutic process is a process. It doesn't mean because you have applied a stimulation that you are healing, you are getting a healing result right away. We are inducing the healing process. That means any mechanical load that we do is a stimulation that would have as an end result stimulating and leading to the healing process. So it takes time. It's not a response. It's not an action healing response process mechanism. It's a process. That means if you don't induce that stimulation, it may take longer. So it doesn't mean because you have done that. You have definitely seen that in other area. If a patient has let me say a fracture, it takes time, but the action that you are putting in place, like handling his fracture, is a mechanism for you to make sure that you facilitate the healing process. So what we are trying to say here in the mechanotransduction mechanism is just to explain that doing that, this is the end result that you are producing. So at the end of the day, the action that you are producing help in the process. It's just part of the process. It's not a magical tool that would be used and just mediate the healing state. So the healing is a process. It takes time. It takes different type of action. And mechanotransduction is just one of the way that you induce that process or you implement that process. Donc, si je vais faire une traduction rapide de ce que je veux dire, c'est que pour Fadimatou, dans sa question de savoir pourquoi, parce que basiquement, ce que Fadimatou demande, si j'ai bien compris sa question, c'est de savoir pourquoi, si le mécanisme de stimulation physique dont on parle, bien que, pourquoi est-ce que dans le cadre des patients hémiplégiques, malgré ce mécanisme, ce patient reste toujours dans les phases hémiplégiques pour une longue période. Donc, ce que j'essaie de lui expliquer, c'est que le mécanisme de mécanotransduction, qui est un mécanisme de stimulation, n'est pas un outil magique et donc la réaction n'est pas forcément immédiate. Donc, il faut savoir que l'ensemble des mécanismes qui sont mis en place, la guérison est un processus. Ça veut dire que sans ce mécanisme et sans stimulation au niveau interne, ça prendra plus de temps. Donc, c'est juste un outil supplémentaire qui vous est donné pour induire des réponses spécifiques. So, I think we have another question. J'espère, Fadimatou, j'espère qu'on a pu répondre à ta question. Il y a une autre question. So, we have another question. Est-ce que toutes ces transductions mécaniques poussent les mêmes réponses chimiques? So, the question is that, are all these transduction mechanisms inducing the same type of chemical responses?
The question is, does mechanical stimulus always create the same chemical responses?
Exactly. I think that's what he means.
So it doesn't.
He's complementing his question by saying, par exemple, l'électrostimulation, le massage, et est-ce que ces deux modalités poussent la même réponse? Like, for example, electrical stimulation and massage, which are two different types of mechanical stimulus, do they produce exactly the same type of chemical responses?
Generally, that might be unknown. they don't always create the same cascade of responses. For instance, there's a certain mechanism when we use laser or infrared light. The technical word is photobiomodulation. And what that does is it kind of wakes up the cell mitochondria to then be more efficient, more active, to help with cell function. That is one particular example that is unique to infrared light and laser therapies. It's not that we can't elicit that with acupuncture or with massage, but various cell pathways may be stimulated by various modalities. This is why it's not necessarily one modality or one intervention that's better than another. It's having access to, many or multiple modalities in order to maximize the efficiency of your treatment.
Donc, pour ceux qui n'ont pas compris l'explication, en fait, de façon profonde, pour toutes les modalités mécaniques ou pour tous les mécanismes de stimulation mécanique, il n'est pas toujours certain que la réponse soit exactement la même. Mais il existe des cas où c'est connu, par exemple dans le cadre de l'utilisation des thérapies laser, où le mécanisme sur les tissus sera complètement différent avec le mécanisme de photo-induction au niveau cellulaire pour stimuler les cellules, qui est différent d'un mécanisme purement physique qui va se produire dans le cadre de certaines autres modalités physiques. Donc, de façon générale, voilà à peu près la réponse qui est donnée. Je ne sais pas s'il y a d'autres questions.
I would add that each physical stimulus is going to have a degree of dosage to it. So when we apply a light pressure, that's going to have a decent, a chemical response, but it might be minimal. Whereas with deep pressure, we might get more of a dose, more of a chemical response. And that's true of any modality, be it electrical stimulation or manual therapy or whatever it may be. And our job is to titrate it so we find what the appropriate dose is. And that's where the expertise comes in.
Yeah, I may even also add to that the nature or the type of tissue that you are applying the mechanical stimulus to may mediate a slightly different response. Like on the tendon, if the mechanical load is on the tendon or on fats or on muscle spindles, might induce, depending on the specific nature of the tissue, might induce with the same type of load a different type of or different degree of response, I guess.
Consider as well that example of Dr. Alfredson. So the dose makes the poison, like what Dr. Nate said. He was having for some reason, the way he was moving was causing those tendons to be irritated such that they couldn't repair themselves. And so instead of resting, he applied a really, really high dose in order to try to rupture the tendons. And that dose then was appropriate enough to then cause those tendons to respond and repair themselves, remodel themselves. So unfortunately, it's not a perfect science of which tissues adapt to which modalities or which interventions the best. This is why it's practicing physical therapy or practicing medicine. But oftentimes that slide I showed you where there's sustained postures, there's tendinopathies, there's arthritis, those are the body absorbing maybe an unnatural force on those structures, and it's causing some breakdown such that then the actual repairing cellular pathways don't get a chance to move through the healing process.
Okay, I think that we are 49 minutes into this presentation, so we are reaching the end. If there are no further questions, we may just drag your guys' attention as we let you know this was the first of a series of webinars that would gonna hold. So our next appointment would be the January 16th, same time. Might be a different platform. A Google Meet probably would be shared with you. The link would be shared with you as in the coming days for the next seminar, for the next webinar, where we would be going deeper into the introduction to the neuromuscular manual therapy, and we'll be going into the basic concepts that will be presented by Dr. Clint. I would introduce a pen neuroscience that would be like more developed by Dr. Nate, and maybe we'll be covering some case reports also on January 16th. So, donc, comme je vous le disais, ce webinaire d'aujourd'hui était le premier d'une série. Donc, celui-ci, nous venons d'en voir le premier, celui du 21. Le 16 janvier, nous en aurons un autre où nous allons couvrir un peu plus en détail. Nous allons rentrer dans les concepts de la thérapie manuelle neuromusculaire, où nous allons couvrir par le docteur Clint la partie sur les concepts de base. J'introduirai personnellement la partie sur la neurosciences de la douleur, qui sera développée et avec une orientation plus clinique par le docteur Nate, et peut-être nous ferons quelques rapports de cas. Et puis, après celle-là, le 20 février, nous aurons une autre avec des démonstrations vidéo de certaines manipulations et ainsi de suite. Je vous invite vivement à continuer à suivre, à regarder. Je vous invite également à regarder cette vidéo une seconde fois pour pouvoir bien comprendre cette partie, parce qu'en réalité, la présentation d'aujourd'hui sur la mécanothérapie est fondamentale à la thérapie manuelle, mais fondamentale à notre pratique en physiothérapie de façon générale. La réponse que nous induisons dans les tissus par les forces que nous appliquons de l'extérieur. Donc, une fois de plus, merci de votre attention. Et comme je vous le disais, ces 3 webinaires vont vous préparer pour le séminaire qui va se tenir au Cameroun, à Yaoundé et à Douala en mars. Ce sera un séminaire de 3 jours pendant lequel le docteur Clint et le docteur Nate et moi-même serons sur place au Cameroun. Nous serons tous les 3 au Cameroun. Et ce sera des séminaires de 3 jours pleins où vous allez être introduits à la thérapie manuelle, où on va pratiquer ensemble chacune des parties, que ce soit de la colonne vertébrale dans la première partie. Et puis, il y aura une deuxième série en fin d'année où on va faire les membres, donc les manipulations de chaque segment vertébral avec leurs indications cliniques. Donc, vous allez être introduits aux techniques afin de ne plus avoir à manipuler les colonnes vertébrales comme beaucoup d'entre nous le font sans les connaissances qui vont avec. Donc, nous allons nous assurer que vous soyez formés à l'utilisation des techniques de thérapie manuelle et que vous puissiez commencer à pratiquer en comprenant clairement ce qui se passe et avec la technique la plus appropriée. So, as I was saying, I was just like letting you know that this webinar that we presented today was the first one of a series of 3. The next webinar would be on Saturday 21. We'll be presenting, no, not Saturday 21. The next would be January 16, actually. That would be on the basic concept, as I said, pen neuroscience that will be further developed by Dr. Clint, by Dr. Nate. And then we will be having on February 20th, another one that will be going more into practical demonstrations. This would be in prelude of the 3-day webinar series, 3-day physical training that will be holding in Yaoundé and in Douala in March. During those seminar in March, you have a hands-on practical training on how to effectively acquire spinal manipulation techniques to make sure that you practice it in a safer way, not like a lot of us are doing, just watching a YouTube video. And this would give you the possibility of a one-to-one for certain, and really a practical and supervised by highly trained professional in manual therapy, so that in the future, you would be able to understand the ins and outs of each of the technique. For the first series, the first webinar series would be mainly on the spinal cord. And then by the end of the year, we may have another one that would go on joint and extremities. So I invite you to listen to this webinar one more time on our page to make sure that you fully understand what is happening. And this is the base of the training. Thank you for your attention, guys. I don't know if you guys have a final word before we end the webinar today.
Hey, thank you very much for giving us your time and attention. And we look forward to the next 2 webinars and certainly to the training in person in March.
Yeah, we've worked really hard on building this content for all of you, and we're excited to travel and to meet in person.
OK. Donc, à tout le monde, allez, merci encore et on se voit comme prévu le 16 janvier pour le prochain webinaire. Merci à tous. OK.